Thank you very much. I'm happy to be back in London. It's not so far this time. I mean, in 1 hour from Brussels, it's very easy travel. So I'm going to try to say something about quality of life, making quality of life better in patients, using, in fact, therapies that are available. And my main aim in Brussels is getting patients better. And by the use of markers and by the use of drugs, sometimes off-label use, that are available and that can increase the quality of life of patients, and some cure. So this is the overview of the different topics I'm going to talk about. I'm not going to talk about HV6 in chronic fatigue syndrome, because Dr. Peterson is the expert here, and I'm not going to intervene with his talk. The types of treatments, there's just one word about this. There are some antiviral therapies out there. There are some immune modulating therapies that are available, like Cutapressin, and in the future maybe Ampligen, that can certainly be used in patients that have a disease where the HV6 is clearly a marker of something that continues the disease that keeps the disease going. So we still come back to Mycoplasma, and the measurement and detection of Mycoplasma is something which is not very easy. And Mycoplasma comes in a situation where the immune system doesn't work properly. You've seen that T cells and NK cells are dysfunctional, and we see a lot of mycoplasmal infections. Now, to be honest, when we diagnose mycoplasmal infections with PCR, we already know that there is a dysfunctional immune system because these two things go together. But finding a mycoplasma, and certainly Mycoplasma fermentans, which is an oncogenic bacterium, we have certainly a reason to give antibiotics for a prolonged time. Nobody likes to give antibiotics for a long time. It has a bad name with hospital infections and so on, resistance. But if you find these kind of bacteria, there is certainly a reason to give it. And there are some open studies that support this in the Gulf War syndrome, and there are in totally three studies, some published, some not, just presented at conferences, that also give good results, and in more than 700 patients total. The study by Nicholson in the Gulf War and in the CFS ME group also showed that there is a clinical response and there is a clinical recovery in 50% of the patients that have gotten a prolonged antibiotic treatment with 2 antibiotics, alternating 2 antibiotics over a period of a year. Chlamydia pneumonia is probably also a player in chronic fatigue syndrome. We know it induces some cytokines chronically. It, in fact, activates the immune system continuously, and it also induced the 2,5A system, and which is a system which is antiviral. But we know that it activates the immune system, and so there's certainly also a reason when you have a persistent chlamydia pneumonia infection in patients, IgAs or PCR positive, there are some reasons to give antibiotics. In the studies that have been conducted at with our group, we saw that azithromycin was a very good therapy here. The Rickettsia, Bartonella, and Coxiella infections in Belgium, we find that 8 to 10% of patients probably have some form of Rickettsia, Bartonella, and Coxiella, Coxiella, that is probably because of the immune system not being functional. They can get rid, patient can get rid of it. And so we find titers that are elevated and indicate chronic infection. Now, I was in Australia recently, and for Coxiella and Rickettsia, they found respectively 39 and 41% of the patients being positive for these microorganisms, and they're intracellular mechanisms, and they're difficult to get rid of. So I don't think that these are the cause of chronic fatigue syndrome, but they're antigens, and if we can get rid of antigens, they keep bugging the immune system and keep activating the immune system, and this is part of the pathophysiology of the disease. Dr. Jardin in South Africa treats these patients with Coxiella, with Rickettsia, and so on for 12 to 18 months with 2 antibiotics, and she uses a combination of 5 very well-known antibiotics, of which she uses 2 and alternates them with periods of 6 to 8 weeks. What's the role of heavy metals in chronic fatigue syndrome? Again, it's probably not the cause of chronic fatigue syndrome, but heavy metals are also immunogenic. They, in fact, play a role in dysregulating the immune system, and I'll show some in vitro data of this later. We use the Melissa test, which is an immune-related test that, in fact, shows the number of receptors on the lymphocytes for certain metals. And we believe that if there is no exposure to metals, there are no receptors on these lymphocytes. And when we found a positive Melissa test for certain metals, we do a DMPS or an EDA test, which means that we collect urine for 24 hours after we injected either DMPS or EDTA, depending on the metal we have found in the Melissa to be elevated. And we get this type of result on the Melissa test. You can see here that mercury and other metals are elevated. The normal line is between 2 and 3 on this scale, and you see this patient has an immune reaction to a lot of metals. Now, we know that in the cells there is a multidrug resistance protein 1, and this multidrug resistant protein 1 is in fact involved in the immune system regulation. It's a T-cell activation marker. And it's also involved in the regulation of cytokine production, in dendritic cells activation, in the Th1, Th2 balance regulation, and it's expressed in Th2, not in Th1. It also has a major role in cellular glutathione homeostasis, and it also mediates the efflux of many toxic chemicals, including heavy metals. So these are all things that we find in chronic fatigue syndrome. These are all dysregulations that we found in chronic fatigue syndrome. Some have done research and found that intracellular glutathione levels are low in ME patients. And so there is a possibility that this protein might become dysfunctional. And when we see in normal circumstances that MRP1 modulates the sensitivity of different cells to mercury. In this slide, we've done an in vitro test on 8 different cell lines. Ramos means one type, a cell line. The MOL3 is a cell line. The U937 is a cell line. And so we took controls in the blue lines. We added mercury to the cells, and then 50% in the Ramos, and in other cells only 10% of cells died. But then when we add a inhibitor of MRP1, which is called MK571, we see that the majority of the cells die off. So it means that if the cells are unable to get rid of the mercury, that more cells die, and what happens then, you have increased cell death, and you have increased pieces of DNA that are liberated into the circulation, and this is maybe a problem in these patients, as I will show later. We know that the expression of an anchor-enriched fragment of RNA cell makes the cell line more sensitive to cytotoxic effect of mercury. And what we did is, when RNA cell is fragmented, as we demonstrated before, when we take one piece of that and we insert it into the cells, we see that, in fact, these cells, they will die at much lower concentration of mercury in the suspension. So the difference on the right slide between the green and the red line shows that if you, in fact, in the U937 cells, when you block certain ion channels with this anchor-rich fragment of RNA cell, you see that 100% of the cells die. So ME patients are probably, and at least a subgroup of them, much more sensitive to certain metals, and it's only mercury and nickel that are the culprits. We don't find any problems with other metals like cadmium or lead. It's the increased cell death is related to mercury and to nickel. There's certainly a reason to, in subgroup of patients, to get rid of these metals, but you have to do the testing first to know if it is a problem. Mycotoxins, neurotoxins, are a big problem since our houses are too well isolated. And one of the important mycotoxins is related to Aspergillus niger, or Niger. We find in a lot of patients high antibody levels. And in about 30% of my patients, I measure it systematically, I find high levels of Aspergillus niger IgG. And it changes when people move from house to house. When they go live somewhere else, you see that the problem slowly fades away. Now, Aspergillus niger has a lot of neurotoxins, mycotoxins related to it, and this also is a problem in chronic fatigue syndrome. It probably is related to the fact that people become more sensitive to it because they cannot eliminate these neurotoxins. The Candida problem, which is still under discussion, is beneficial. The treatment is beneficial in some patients, not in all of them. And some have given patients a long-term antifungal therapy to get rid of the Candida intestinal tract. And we try to look at IgG levels of Candida in patients to see if this plays a role in a particular patient. Again, this is not present in all the patients. So I want to talk in the second part of this presentation on the digestive tract. Digestive tract is part of the immune system, and as you might know, 70% of the immune cells are present in the digestive tract. So when you take the small and the large intestine and you cut it open and you iron it, then you have the surface of a soccer field. So it's an enormous surface, and the number of immune cells is relatively high because 70% of all immune cells are in the intestine. So when something happens to these immune cells, when they're attacked by a virus or by something else, our whole digestion, motility, absorption, and secretion might become abnormal because you change the bacterial content of the digestive tract, because these immune cells, they are involved in tolerance, they are involved in recognition of bacteria, and they also are play a role in digestion. Secretion of enzyme is indirectly regulated by the immune system. So what was developed for these patients was the measurement of IgAs and IgMs in the serum for normal gram-negative bacteria. Hafnia, Pseudomonas, Morganella, Proteus, Pseudomonas putida, and Citrobacter all are typically intestinal bacteria that you don't find anywhere else. You find in the digestive tract. And what we saw is, I have data now in about 2,000 patients. what you find is that a lot of these patients have IgMs, certainly IgMs for these bacteria, early antibodies persistently, and measured 2 or 3 months with an interval of 2 or 3 months, and you always find the same thing. So there is what we call bacterial transfection. It's the only explanation for this is bacterial transfection, and in Nature Medicine in December, it was shown that in HIV, the same thing happens. So a virus causes the same thing in HIV patients. This publication showed that when patients come from a carrier of HIV and develop AIDS, develop HIV disease, that the difference is that a chronic inflammation starts by transfection of bacteria from the gut to the lymph and to the serum. We did a preliminary study, which I've shown already a few times, is in 44 patients. We treated them with 1 week of antibiotics and followed by 3 weeks of probiotics for 3 months, so cycles of a month. And we measured elastase. Elastase is an inflammatory marker. Elastase is produced by monocytes and by neutrophils, and we showed that it decreased by 74%, and in 43 out of 44 patients. After 3 months, we had a 58% of the group that had clinical improvement, and that means that they had at least an increase in Karnofsky score of 20 points. So what are the consequences of this leaky gut syndrome, as we can call it? Transfection of bacteria or leaky gut. And what are the interrelationship with CFS? Where is the problem? Well, we find, and these data are not published yet, but we found LPS from bacteria in the blood of patients, and in other subgroups of patients, we find more gram-negative bacteria, and in these patients, you find peptoglycans. These are very immunogenic. LPS of bacteria and also peptoglycans induce the immune system through toll-like receptors and activate protein kinase. This increases prostaglandin E2, induces nitric oxide synthetase, and also induces COX-2, and the ratio COX-1, COX-2 is changed. The consequences of increased prostaglandin 2 is inflammatory syndrome, peripheral vasoconstriction, cold hands, and so on. Increase in thrombocytes, and a subgroup of patients has a mildly elevated thrombocytosis. Blood viscosity goes up, and premenstrual syndrome is also a problem in this group. The NO related is you get gastric reflux, impaired memory, your Th1 immunity goes down, you have more mycosis, reactivate herpes viruses, you have slowing of gastric emptying, chlamydia infections, low blood pressure, peripheral vasoconstriction, and low intercellular nitric oxide. And the COX-2 also leads to inflammatory syndrome, gastritis, and also has an impact on natural killer cell number and low NK activity, which are things that we regularly find in these patients. So microbial products originating in gastrointestinal tract are the cause of HIV-related systemic immune activation. This was published, in fact, 5 months ago. And circulating LPS is an indicator of microbial translocation, and these are significantly increased in chronically HIV-infected patients, and I now can add also in CFS patients. LPS is bioactive in vivo and correlates with measures of innate and adaptive immune activation. We know that there is evidence of in vivo stimulation of monocytes by LPS. There's also an association between in vivo stimulation and measures of innate and adaptive immune activation. And a compromised gastrointestinal mucosa surface is a mechanism for chronic immune activation. And as I come back again, a virus or viruses can play a role in this. the study published 5 months ago also showed that the immune activator decreased after initiation of an antiretroviral therapy, showing again this is an important mechanism. So in CFS-ME patients, we find in serum IgA for intestinal aerobic bacteria, we find IgM for intestinal lactotic bacteria, we find high plasma LPS levels in some patients, and in the majority of patients, we find high leukocyte elastase activity in the monocytes. So what causes the damage to the epithelial barrier, thus augmenting microbial translocation and fueling the systemic immune activation? Is it DBV? Is it herpes 6? Are there other viruses? We will know in a few months, I think. A lot of groups are doing this research. Is it all of them? Is it just an overload? Or is it also the fact that the mucosal CD4 or CD8 cells or NK cells become depleted after a while, because we see a number of patients that had salmonella infection as a trigger for their disease and not necessarily a virus. So I think personally that there are a lot of triggers possible that change the mucosa and increase microbial translocation. I will shortly talk about peripheral resistance to T3. I've talked about this in the past, but to make it simple is that in CFS there are proteins present that are homologous to thyroid hormone receptor interacting protein. And they, in fact, bind with the T3 receptor. They have an homology of 98%, and they are going to sit on the receptor so that the T3 hormone cannot do its work. And in fact, in some instances, they will sit longer on the receptor and destroy the receptor. So this is one of the reasons why people who had ME for 30, 40 years have a clinical look like patients with hypothyroidism, but their T3 and T4 levels are normal in the blood, but they have all the clinical features of hypothyroidism. Still, we try to treat those patients with low dose of T3 because there is no peripheral conversion. There's no demand for T3 because the receptors are blocked. So we try to create some competition between these proteins that block the receptors and T3 by giving some extra T3. And there is a US doctor named Teitelbaum who's been doing this for a long time, but without any scientific evidence so far. So the therapeutic strategies that we use in Brussels are restoration of immune competence with all the methods possible, trying to normalize the Th1-Th2 ratio, because if the Th1-Th2 ratio goes down, we see reactivation of herpes viruses. We try to eliminate and decrease the load of certain microorganisms. We try to restore hormonal balance, and there's not only a problem with the T3, there is a problem in several parts of the hormonal system. We try to restore the intestinal flora. We try to decrease PKR activity, and then certainly the nitric oxides and the peroxynitrate with vitamin B12. And we also treat the metal allergy. And personally, the person that came up with the Melissa test says that it is a genetic test. I don't think it's a genetic test, because if you treat the patients with chelation for the metals, then the Melissa test becomes normal. So I don't think it's really a genetic test, otherwise it wouldn't really change. So this is the current strategy, and we adapt our strategy continuously based on scientific reports, and we hope that we can get better treatments, but so far we have to do it with everything that we have. Thank you.
Hi, it's Mark Eagle here. I'm not sure exactly what my question is, but for your average patient in the UK, your strategy seems to involve a lot of testing and a lot of sort of input from a doctor. Mm-hmm. But your average patient in the UK ends up seeing a GP who's not really clued up on this sort of stuff. And I mean, I've had the tests for RNase L and the elastase done, and they come up positive. But I can't really you can't really take it any further because you go to your doctor and you say, well, this probably indicates that I have like a viral infection or a bacterial infection. How about an antiviral treatment? Just testing that. So basically, it still doesn't sort of help your average patient in the UK. How would do you have a sort of a layman's guide to what someone who could sort of follow your treatment protocol?
I have it with me now.
Oh, right, fantastic.
Yeah. But no, I mean, the diagnostic testing, the markers, it's not like a supermarket where you just take a few things. There is a diagnostic algorithm where and the problem is the English patients I see, they're in a hurry. Everything needs to be done in one day. And it's a problem because if you want to do it in a diagnostic algorithm, you have to draw blood and do a few markers, and then from that you make a decision to do another few markers. So you don't have to do 50, but with maybe 8 or 10 markers, you can have a pretty good idea what's going on, and you can do this very cost effective. But you can do it two ways. You can just order 50 tests, and then you have the whole picture. If there's an economic problem, then you can start with a few. And there's a website where I can refer you to, just with 4 markers. And then you go down a line depending on the results of these markers. Okay. And you don't have to do all 50 markers. There's a basic panel of about €400 or €500. If you want to go then further, it's maybe another €400 or €500. Well, the treatment is I don't know. The English patients I see, they get reimbursement because we use conventional drugs. We use conventional therapy. In Belgium, we have for supplements like chelation or natural chelation, the insurance companies pay 50%. Right. So there is a system, and we try to find things that are scientifically right, at the same time see if they're economically viable. Because, but again, it's the politics of the disease that keeps the patients from being reimbursed. If you see a total cost of £2,000 as a lot of money, I don't see that as a lot of money if this changes your life the next 20 years.